disorders of the hip and the assessment and management of these. Before we look at the physiotherapy interventions, however, it would be really useful if you can review some of these common disorders of the hip and the anatomy, both bony anatomy and muscular anatomy of the hip, in order to help inform this. You need to revise the bony anatomy of the hip joint, and the key common features that you need to consider are the femur, and it's particularly the features of the greater trochanter, the neck of femur, and the head of the femur. These are commonly implicated in hip conditions. Review other bony features of the pelvis, such as the iliac crest, the anterior superior iliac spine, the posterior superior iliac spine, the ischial tuberosity, and the pubic crest. Having a good knowledge of anatomy of the hip, pelvis, and upper femur will certainly help you understand some of these common disorders. You also need to revise the muscles that occur around the hip and their major actions. So make sure that you know about the glutei group, gluteus maximus, medius, and minimus. Consider piriformis, obturator internus, quadratus ephemeris, and then the anterior muscles such as iliopsoas, pectineus, sartorius, adductor longus, adductor magnus, and the tensor fascia lata. For this particular module, it's not particularly important that you're aware of the precise origins and insertions, but it is particularly important that you're aware of their actions. Some of the common problems that you might see at the hip are listed here. We're not going to cover every single one of them because some of them are more come under the more general arthropathies, but we're particularly going to focus on osteoarthritis, fractures, hip fractures, particularly fractured neck of femur. We're going to look at Perthes disease, which is also sometimes known as leg calvus Perthes disease. We're going to look at greater trochanteric pain syndrome and femoroacetabular impingement syndrome. Some of the other conditions that are shown here, such as developmental dysplasia, slipped capital femoral epiphysis, and avascular necrosis, are sort of also commonly associated with Perthes disease and maybe actually sort of overlap each other a little bit. Likewise, labral tears can also come under femoroacetabular impingement and greater trochanteric pain syndrome. Osteoporosis is a common problem, but that's much more generic, but make sure that you're aware of the implications of osteoporosis. So all of these problems are worth you knowing about, but we're going to focus just on some of them here today. Osteoarthritis is probably the most common of the hip conditions. It's the second most common osteoarthritic condition after knee, and it affects significant numbers of people across the UK. Osteoarthritis is a degenerative joint disease. You might hear it sometimes called wear and tear, but that's not necessarily a very accurate description of osteoarthritis. It's twice as common in women than men, and it commonly affects people over the age of 45. You'll see from the image here, it's characterised on radiograph by narrowing of the joint space and may include bony growths called osteophytes. Patients with osteoarthritis typically report a dull ache, often in the groin, and it will progressively get worse as the patient gets older. It will be worse at the end of the day or on physical activity, particularly walking and doing stairs are commonly reported as painful. There may or may not be night pain, or pain that keeps them awake at night. And on assessment, you may see reduced internal rotation. Although radiographs are commonly used in diagnosis of hip osteoarthritis, the sort of common symptoms that can usually be fairly reliably diagnosed on are the age and the signs and symptoms. The next condition that we're particularly interested in is a neck of femur fracture. These are quite common, particularly in older women, and is often associated with osteoporosis. So the fracture occurs often as a result of a fall when the bone is not strong, it's brittle and fractures much more easily. A neck of femur fracture is characterised by a shortened and internally rotated leg, and even before the imaging has been taken, that's a fairly predictive sign that somebody has suffered from a neck of femur fracture. You can see here on the image a quite clear fracture. They are classified in different ways, and how they're classified will depend on the treatment, but they're usually treated with surgery. So they may have some internal metalwork such as a dynamic hip screw or an intramedullary femoral nail, or in some cases, or many cases, the patient will progress to a hip replacement. The next condition that we're considering here is greater trochanteric pain syndrome, or used to be called trochanteric bursitis. And it's a common cause of hip pain affecting sort of roughly 1.8 per thousand of the population. Whilst it used to be called trochanteric bursitis because it thought that the bursa was the particular source of the pain here, more recent research has shown that it's thought more likely to be a tendinopathy of gluteus medius and or minimus, and it may include the bursa but not always, so the trochanteric bursa. And the source of the pain is thought to be compression of the tendons and or the bursa over the greater trochanter by the iliotibial band. So you get impingement of the tendons, of the medius minimus tendons by the iliotibial band. This causes lateral hip pain and tenderness over the greater trochanter. Generally it's worse on activity and side-lying on the affected side. It may progressively get worse sort of over a period of time, but it can also occur as in a more sudden onset with a bout of sustained physical activity. Spears and Bogal in 2017 offered this kind of differential kind of diagnosis between greater trochanteric pain syndrome and hip OA. So both hip OA and greater trochanteric pain syndrome will have pain on activity. But if it's pain in side-lying, which is disrupting sleep compared to just general pain, then that's more likely to GTPS. And the very specific palpation of the greater trochanter, which is causing pain, and in fact it's called the jump test in some circumstances. It can be that tender. So press on the greater trochanter and you'll get the patient jumps off the bed, then it's more likely to be GTPS. Pain on straight leg raise for 30 seconds is also, then all those things together is thought to lead to a differential diagnosis of GTPS. Whereas reduced sort of activities of daily living, overall reduced movement, and pain on internal external rotation of the hip is more likely to be OA. Now we always need to rule out other joints, and particularly with pain around the hip, you would want to rule out lumbar spine. So you do want to think about your joints above and below, and in this case the joint above is the lumbar spine. So sometimes you may get radiation of pain to the lateral hip. So in which case, to differentiate between hip pain caused by GTPS or the lumbar spine, you would want to palpate the back as well and look at the reduced movement of the back and look for other symptoms of lumbar spine pathology. Both things like osteoarthritis and neck of femur fracture are more likely to be seen in older people. Femoral acetabular impingement syndrome, however, is something that can be seen in people no matter what age. So there's two types of FAI, as it's called. A pincer type FAI is where you get growth of the acetabulum, which extends over the normal rim of the acetabulum and can actually cause impingement or pain as it nips against the labrum. The CAM type is where you get a sort of misshapen femoral head, which causes a bump in the femoral head, which again kind of causes impingement on the acetabulum and causes a problem with the cartilage as well. So you can get the pincer type, which is acetabulum, the CAM type, which is femoral head, sort of misshapen, or you can get a combination of both. Hip problems can be difficult to diagnose because FAI will cause you pain in the groin area, similar to OA. It will cause you stiffness in the hip, which can be similar to OA. And clicking, catching, locking, or giving way may also be reported, with frequently reported weak hip muscles. And all of these things can be reported in OA too. And indeed, FAI can lead to hip OA in the long run too. So the differential diagnosis of these things can be problematic. So now thinking about one of the typical problems that we might see, which is not necessarily in older people, but this is something that often starts in early life. So Perthes disease, or leg-calf Perthes disease, is where the blood supply to the femoral epiphysis, so the growth plate of the head of the femur, is compromised. It often begins in children aged 4 to 12, but obviously that's just a rough estimate, and is thought to be 3 to 4 times more common in boys than girls. Untreated, it may cause a permanent femoral head deformity and then subsequently lead to osteoarthritis in later life. So you may see older people who still have that kind of diagnosis, but that's not because it's particularly active now, but it caused femoral head deformity in early life, which has now led to OA. So children will typically present with pain in the hip and groin. They may be limping, muscle weakness, particularly in the quadriceps and the gluteus group. And as you can see from the picture here, quite significantly reduced internal rotation at the hip, but you'll also see reduced abduction as well.